My name is Lorenzo Tinti. I'm a clinical neurophysiologist working in Milan, Italy. And today I will talk about our study within the Prospective Studies Working Group of the Curing Coma campaign. Basically, we have developed a narrative review of studies on coma and disorders of consciousness to try and identify common limitations and pitfalls that could have limited our knowledge so far. So our first consideration is that coma as a condition is a consequence of many diverse acute brain injuries like trauma or cardiac arrest or strokes. And while we have some good knowledge about how to manage these underlying conditions, we still strive to properly define, manage, and follow up the associated disorders of consciousness, including coma. This is a problem because without adequate shared definitions, it can be very hard to gather informative data and to plan clinical trials for treatment. So we found that previous studies have adopted a wide range of inclusion criteria, follow-up timings, many different definitions of important outcomes and of clinical variables to account for, and altogether very different and heterogeneous study designs. So in our paper, we outlined what are the most common obstacles that investigators face when they are planning studies on this topic and provide some practical suggestions to streamline data gathering. First of all, we have discussed the problem of having a reference population because we know these patients are managed by different healthcare professionals, both at the acute and at the chronic stage, so recruitment should span a variety of contexts and not just be limited to, let's say, only intensive care units, stroke units, or only emergency departments separately. Secondly, we pointed out the lack of a comprehensive definition of coma based on solid neurobiological knowledge. Therefore, investigators have been relying on operative, mainly behavioral definitions of coma. However, the exact criteria are not homogeneous, as shown by the Come Together survey by the Curing Coma campaign. Also, we still don't know precisely the timing for emergence from coma to awakening, or in other instances, persistent disorders of consciousness, like minimal conscious state or unresponsive wakefulness syndrome. Also, when enrolling patients prospectively in studies, we stress the importance of evaluating for clinical confounders, for example, metabolic derangements or focal neurological deficits. We also discuss how to select useful outcomes and comprehensive scales for following up patients and define their progression, both in the ICU and in the long-term facilities. Finally, we discussed the choice of clinical variables to account for in clinical studies and statistical tools to analyze this data meaningfully. Altogether, we called for a multidisciplinary evaluation of coma and DOC patients from the acute to the chronic stage. Thank you.